So now I am going to introduce Kip Sullivan. Kip has been an organizer and researcher for organizations that have been dedicated to enacting single-payer legislation for over 3 decades. He helped co-found several of those organizations, including Minnesota's Physicians for a National Health program, as well as Healthcare for All Minnesota. He is nationally published, having written several hundred articles about healthcare reform. He also participated in crafting our state single-payer bill, the Minnesota Health Plan. With that, I give you Dr. Kip Sullivan.
Do I, it works. Thank you much, everybody. Thank you, Rose. Thank you, Scott. I have been working at this for more than three decades. A lot of people have. We haven't gotten to single-payer Medicare for all, but I love getting up in the morning and working for this. It's a beautiful fight. I love the people I work with. And I'm not employed anymore. Currently, I'm a volunteer, but I'll be doing it until I've got no more breath to do it. My job is to explain to you in about 20 minutes how it is that the Medicare Advantage plans, the insurance companies, who did not want to insure the poor prior to 1965 and did not want to insure the elderly prior to 1965, are falling all over themselves to participate in Medicaid and Medicare. 58 years ago tomorrow, President Johnson signed Medicare and Medicaid into law. Congress enacted Medicare for the elderly and Medicaid for some of the poor because the insurance industry didn't want the elderly and the poor. Yet today, half of all Medicare beneficiaries are insured by an insurance company, and 3/4 across the nation of Medicaid beneficiaries are insured by an insurance company. How did that happen? Your common sense tells you it happened because they're overpaid, and your common sense is correct. In Medicare's case, the so-called Medicare Advantage plans, that's the name of the program that was conferred upon the privatized portion of Medicare in 2003. In the case of the so-called Medicare Advantage plans, they are overpaid by at least 30% and possibly 40%, and it used to be worse. That's easily $100 billion a year we waste on these bloated and predatory insurance companies. We must persuade Congress to terminate these overpayments. If the overpayments aren't cut, everyone's taxes will go up, or seniors and disabled services will be cut for seniors and disabled people. To persuade Congress to cut these overpayments, we must be able to explain to Congress, the media, and the public what's causing them. Unfortunately, there isn't just one cause. It would be so much easier if we could point to one statute that Congress passed years ago that ordered CMS, that's the name of the agency that runs Medicare, the Centers for Medicare and Medicaid Services, that ordered CMS to pay Medicare Advantage plans 30% more than necessary. But that's not how it happened. It happened because Congress enacted 3 laws with little forethought and then did nothing for years as it became apparent that the laws had authorized huge overpayments to these insurance companies. The first of these laws was passed in 1972. That was the one that inserted the first insurance companies into Medicare. 6 years after Medicare started operation, that's when Congress first got it into their heads. Let's put HMOs into Medicare because that will make things better. Lower costs, improve quality. The second of the 3 laws I'm talking about was the Balanced Budget Act of 1997, and the third was the Affordable Care Act of 2010. The simplest way to explain how the overpayments happened is to give you a very quick, short history of how Congress tacked on all these subsidies. Between 1972 and 2004, there was one cause of the overpayments. Between 2004 and 2012, there were 2 causes. And since 2012, there have been 4 causes. I'm going to go through each of these phases, one at a time. Between 1972 and 2004, the insurance companies were overpaid because they enrolled unusually healthy Medicare beneficiaries, but they were paid as if they enrolled beneficiaries in average health. That phenomenon is known as favorable selection. And I'm going to illustrate this several times with an example. Imagine that the average cost today of a Medicare beneficiary in the traditional program is $10,000 a year. Imagine at the end of this coming year, Medica, which is an insurance company that sells Medicare Advantage insurance, imagine that they enroll people who on average cost $9,000 a year. If Medicare pays them $10,000, they have overpaid them $9,000. There's no way you save money if you do something like that. Now, CMS, over the years, made a feeble effort to adjust the premium payments to the Medicare Advantage plans downward to reflect the superior health status of the Medicare Advantage enrollees. That process of pushing those premiums downward to reflect health status is called risk adjustment. But until 2004, the only information that CMS used to adjust premiums was age and sex. That is almost worthless. Imagine, for example, all women between the ages of 70 and 75. I mean, the variation in that cohort is immense. It tells you very little. It explains 1% of the variation in statistics speak. Now, sometimes that concept of the 1% of variation is a little hard to understand, so I'm going to illustrate it two ways. Once here, and they want to get into the slides, I'm going to illustrate it a second way. Here's the simplest way to explain. Let's go back to that $1,000 overpayment to Medica. They should be paid $9,000, but they're paid $10,000. The feeble risk adjuster that CMS used for many decades, age and sex, only explained 1% of that overpayment. And so they reduced the overpayment by $10, 1% of 1,000. And they paid Medica $990, $9,990 instead of $9,000. You might as well not even bother to pay the electricity for a computer to adjust so meaninglessly. In the 80s and 90s, you'll see a slide on this, favorable selection coupled with awful risk adjustment was probably overpaying the HMOs that participated in Medicare by 30 or 40%. Favorable selection alone was overpaying them 30 or 40% back then. Now, as they have enrolled more and more seniors, the Medicare Advantage plans are finding it harder and harder to avoid the sick. And so the favorable selection these days is probably overpaying them by about 15%. So that's factor number one. We're going to discuss four. Now, between 2004 and 2012, there were two causes. Favorable selection continued to be a problem, and along came a problem called upcoding. How did that happen? Upcoding is defined as adding to a patient's medical record a diagnosis that is either false or it's accurate but it's irrelevant to the treatment for which the Medicare Advantage plan is being billed. So it's false to say to put a cancer diagnosis on a patient medical record if the patient doesn't have cancer. And it's irrelevant if the patient comes in for a sprained ankle and they have cancer. Both putting cancer on a patient's medical record for either reason is upcoding. Both of these forms of upcoding make the patient look sicker. And since 2004, the insurance companies get paid more if they can make their patients look sicker. Here's how it happened. In 1997, you're going to see some, when I get to the slides, numerous reports warning Congress, you are vastly overpaying the HMOs, get off your duffs and fix it. Well, finally in 1997, they did make a somewhat genuine attempt to fix it. They passed the Balanced Budget Act, and that act ordered CMS to use diagnoses in addition to age and sex in their risk adjuster. Logical, right? I mean, if you have diabetes, you're probably a lot more expensive than the average Medicare beneficiary. Well, didn't go well. They rolled out the new diagnosis-based risk adjuster between 2004 and 2006. It improved the accuracy of the risk adjuster from 1% to 12%. Not much. So if we go back to the $1,000 overpayment example, now what we're saying is with the new diagnosis-based risk adjuster, CMS is now paying them $9,880, and they clawed back 120. Well, 120 is better than 10, but not much. Well, so what went wrong? Well, the new diagnosis-based risk adjuster gave the insurance companies a new way to cheat, upcoding. They began to do it frantically. It appears that upcoding is now costing us an additional 5%. It's adding 5% to their overpayments because the insurance companies are so aggressive at adding diagnoses to patient medical records. Meanwhile, doctors who are treating beneficiaries in the traditional program, they're not doing that. They have no incentive to, and have different values. Congress has tried to play whack-a-mole with the insurance companies that are upcoding. After it became obvious that they were upcoding, Congress authorized CMS to reduce across the board Medicare Advantage payments, first by 3%, and then by 5%, and then by 6%, but they just couldn't keep up with these aggressive insurance companies. And the latest estimate is that despite these payment cuts that CMS is authorized to do to compensate for upcoding, the insurance companies are still beating them, and they're booking an extra 5% in their payments thanks to upcoding. So from up until 2012, there were these two causes of overpayment: favorable selection and upcoding. Favorable selection is probably adding 15%. Upcoding is adding 5%. You'd think 20% would be enough to make them happy. You'd be wrong. In 2010, Democrats were persuaded, when they were writing the Affordable Care Act, to add on even more subsidies. They included a law that says we want CMS to pay Medicare Advantage plans more if they score at least 4 stars out of 5 on CMS's goofy little worthless quality measurement. The quality measurement that CMS uses for Medicare Advantage plans is so worthless that even the Medicare Payment Advisory Commission, which loves Medicare Advantage, has called for its repeal. And the other bonus that Congress gave the Medicare Advantage plans through the Affordable Care Act was to pay Medicare Advantage plans more if they sell insurance in relatively rural counties where the cost of insuring traditional Medicare beneficiaries is a little lower than average. And I'm just going to refer to that as the county bonus. So you put the county bonus, and both the county bonus and the quality bonus took effect in 2012. You put the two together, and that added about another 8% to the subsidies, according to MedPAC's latest estimate. So those are the 4 causes. Now I want to take another 10 minutes just to go back over what I just told you, but with some more documentation and detail. I've got more slides here than I can use, but I'm going to wrap up in about 10 minutes. First, some definitions. Medicare Advantage is the name that was given to Medicare as of 2001. As of 2003. It used to be called Medicare Plus Choice. There's a typo here that didn't get corrected quite right. Yeah, I've got the dates wrong here. Medicare Advantage got its name in 2003. Before that, it was called the Medicare Plus Choice Program. And before 1997, it was just called the HMO program. I'm just going to keep referring to this insurance program by its current name. Skip down the Centers for Medicare and Medicaid Services, CMS. That's the agency that runs Medicare. It got its name in 2001. Now, I call your attention to these 2 forms of jargon: capitation and fee-for-service. Capitation is really synonymous with premium. CMS is paying these Medicare Advantage plans by capitation/premium. In the traditional Medicare program, they're paying doctors and hospitals, they're reimbursing them after the patients have come in and after the doctor or the hospital has provided a service. There's no looking forward trying to guess who's going to get what health care. It doesn't happen in the traditional Medicare program. They're paying fee for service. But in the Medicare Advantage program, CMS has the unattractive job of figuring out at the beginning of every calendar year how much Medica and United Healthcare and Health Partners and Blue Cross, how much money they need to cover the services of the people who just enrolled in them. I think, as you all know, open enrollment occurs between about roughly November 15 and December 7 of every year. And then enrollment closes. So CMS has about 3 weeks at the end of the year to figure out, okay, we know who's enrolled in Medica, et cetera, and now we have 3 weeks to figure out how much to pay, how much capitation or premium payment to pay each of these insurance companies. And they used to do that solely on age and sex. Now they've got this slightly improved risk adjuster. That's why this is so difficult, and they're never going to get accurate. And the last definitional issue here is MedPAC, the Medicare Payment Advisory Commission. You'll hear me refer to it often because they really, Congress listens to them on Medicare issues. Here are the 3 laws I'm talking about. The Social Security amendments in 1972. It's the law that inserted HMOs into Medicare. The Balanced Budget Act of 1997 is the law in which Congress tried to fix the favorable selection problem and made it worse by facilitating upcoding. And the Affordable Care Act of 2010 added the county and quality bonuses. Now here is the total damage. Here you see all 4 factors in one column. Favorable selection, deselection, plus bad risk adjustment is 15%. I didn't mention favorable deselection in my opening statement, but I don't think I'm telling this crowd anything new. You know that Medicare Advantage plans are good at harming their sicker patients. And often what happens is the sicker patients will say, I've had enough, I'm going back to the traditional Medicare program. Well, what does that do? It beefs up the favorable selection. It means the remaining pool of Medicare Advantage enrollees is healthier even more than the people in the traditional Medicare. We don't have good research on what favorable deselection is saving the plans. We just know it's something, and I've listed it here just to make sure everybody pays attention to it. Upcoding, even after taking into account CMS's deflator, adds another 5%, and the quality and county bonuses together add 8%. It's a little unclear from year to year whether it's an even split, 4%, 4%, or something different. This last factor, I just want you to know that you people to leave here today and say, you've heard about it. Induced utilization is, I don't have time to explain it, but some people who have a lot of credibility started talking about it last year. It could add another 14% to the overpayments to the Medicare Advantage plans. In short, we're on firm ground saying that Medicare Advantage plans today are currently overpaid on the order of 30 to 40%. To give you some idea of how happy that makes the insurance industry, look at this one. This is recent research showing that Medicare has become the insurance industry golden goose. They make far more money per enrollee off of Medicare. The program we had to pass because the insurance industry didn't want the elderly, they now make far more money off of it than they do off Medicaid or their private enrollees. Here's another indication of what overpayment has done. We see now, as of last year, the Medicare Advantage plans enroll 50% of the entire Medicare population. Rose mentioned something called ACOs. We really do need to pay attention to them, accountable care organizations. They are making inroads here as well. You can think of them as HMOs on training wheels. Here's the study I referred to earlier. At the bottom, I don't know if you can see, yeah, I guess you can read it. This says the Physician Payment Review Commission, Annual Report to Congress, 1996. And this is the report that said in the 80s and 90s, the HMOs were enrolling people who on average were cost 60% as much as the average traditional Medicare beneficiaries cost. And yet, because of awful risk adjustment, they were being paid as if they enrolled people of average health. Here are 2 examples of reports to Congress saying, wake up, we are overpaying the HMOs. Look at the red dates, 1995 and 2005. Look at the top one, U.S. General Accounting Office. The title was, Growing Enrollment Adds Urgency to Fixing HMO Payment Problem. Quote, Medicare has paid HMOs more than it would have paid for the same patient's care by fee-for-service providers. The next report, 10 years later, same message. Payments exceed cost of fee-for-service benefits, adding billions to spending. Should have been tens of billions back then. Look at the opening sentence. It is largely excess payments, not managed care efficiencies, that enables plans to attract beneficiaries by offering a benefit package that is more comprehensive than Congress will allow the traditional program to offer. Here's the latest, one of the latest studies we have on how bad favorable selection is. I hope you can see, yeah, I guess you can see in the left bar, you see that beneficiaries who stayed in the traditional Medicare program in 2016 cost a little more than $9,000 per enrollee. Those who switched into Medicare Advantage cost a little more than $8,000, the difference being 13%. Not quite as big as it was in the 80s and 90s, but enormous in any event. Here is a very definitive statement from MedPAC in a report to Congress a little over a year ago. The Medicare Advantage program was expected to reduce Medicare spending, but private plans in the aggregate have never produced savings for Medicare. Don't you get the impression that you're just beating on the head of a mule? God, pay attention, please. I won't go over this. We've already done this. Okay, this was the first illustration of what a 1% variation means. Remember, that's where Medica walks to the bank with $990 overpayment. Now, here is the other way to illustrate how bad a 1% risk adjuster is. What you see here in this chart is Medicare beneficiaries divided into fifths. The healthiest quintile, the healthiest fifth, is in the left bar, this one closest to me. The next healthiest is in the next bar to the right, and if you go way over to the right, you see the sickest 1%. This is how badly CMS's old 1% risk adjuster worked. It overpaid for the healthiest 20% by 166%. No wonder the insurance companies wanted the healthy. And you go over to the far right column, and you see that CMS's wonderful risk adjuster only paid insurance companies 17 cents on the dollar. No wonder they don't want sick people. And if they can't avoid them, no wonder they screw them. So along comes the Balanced Budget Act. They tell CMS you got to add diagnoses to your lousy risk adjuster, and that improves the accuracy to 12%. Now we're back to my second method of illustrating how bad a 12% risk adjuster is. Now you see the same chart. Look again at the left bar, and you see now they're only overpaying by 62%. 62% is better than 166% when you were working with a 1% risk adjuster, but it's still lousy. And go to the far right side, you see that now CMS is paying Medicare Advantage plans 71 cents on the dollar, which sure as heck beats 17%, but these numbers still give them immense incentive to walk away from the sick, hurt the sick if they can't avoid them, and to seek to cherry pick the healthy. And if you don't correct that, no wonder they're overpaid. No wonder they love Medicare. Here is, I'll take 2 more minutes and I'm done. The Department of Justice is starting to sue some of these Medicare Advantage plans for upcoding. Here is a report on the DOJ's suit against Kaiser Permanente, the poster child for HMOs. A report from Modern Healthcare. Kaiser Permanente allegedly coerced employees to upcode claims for Medicare Advantage beneficiaries, resulting in an estimated 75% error rate, according to the DOJ. Looked at the bottom, more than half of Kaiser physicians said they were forced to add diagnoses they did not consider, evaluate, or treat. Get this. Kaiser would orchestrate coding parties where physicians would scan lists of diagnoses and add them to their patient visit records. And each added diagnosis netted Kaiser an additional $3,000. I won't tarry here. I'm a little past my time. I'll end here. Remember I told you that the new risk adjuster, the one that added diagnoses, was phased in between 2004 and 2006? Well, look at this chart. This chart shows you the growth in total Medicare Advantage enrollment between what, 1999 and 2019. And by the way, if we could move this out to 2022, we would go from 34% enrolled in Medicare Advantage plans to 50%. But look where the change happened. I don't know if you can see the years at the bottom, but you see that the slight decline stops around 2004. There's a little increase in 2005, and wham, after 2006, massive enrollment. I have not seen a study on this, but my brain tells me the reason this happened is that the new risk adjuster was so bad it didn't claw back a lot of the overpayment, but what it did was to give the insurance companies the opportunity to upcode, and upcoding paid off so well that they now had a lot more money to offer much better coverage to Medicare beneficiaries, and that pulled many more beneficiaries out of the traditional Medicare program and into Medicare Advantage. I've already mentioned the quality and county bonuses. I won't stop to define them anymore. That summarizes the 4 causes. Favorable selection is probably 15%. Upcoding is probably another 5%, and the county and quality bonuses are doing another 8%, and if we count the induced utilization, we're up to 40%. I think it is very complicated to try to calculate how much these subsidies are helping the insurance companies, but I hope you agree with me, it isn't rocket science. It's fairly easy to explain these 4 causes, and we need to tell Congress and the public about them, and we need to stop them. Thank you.